vortex causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to
Yeah, I don't need to hear every little ache, but if it's bothering you, let me know. All right, so while we're doing this, we don't have a true AP. On the x-ray, we want to get that spinous process between the eyes, basically between the pedicles at kind of the L4-5, L5S1 the other way. Just for reference, there you go, that's better. A little more? I'd say just a little bit more. So I've said this 1,000 times by now with these surgeries that the x-ray that we navigate with, let's go lateral. The x-ray that we use to navigate is very important. We need to get the blood pressure down a little bit. So I'm just going to wait a minute until you do that. I'll just talk. We're just going to get your blood pressure a little lower, okay? So there's a window where blood pressure is acceptable for surgery, and for this type of surgery where surgeon likes it is generally systolic blood pressure around 90 to 110 maximum. So about 20 points between 90 and 110. Higher than 110, you're going to just have more bleeding than you really need to, and it can give you a little bit of bruising in the skin and muscle, and basically we don't want that. Yeah, just line up L4-5 nicely. I mean, it looks good to me, to be quite honest with you. All right, so let's show everybody the L4-5. Very good. And then the disc below, go to L5S1 right there. Good. Now, you can see the front to back dimension of that disc at L5S1 is not normal. It's not the same as the L4-5. It's about 2/3 of the width. So it's not a real disc. And then go to the facet joints in the back. Yeah, right there. Those are the facets. Typically, when you have a pseudodisc, the facets are not real facet joints. They're actually fused together. So this is an embryological thing where you're in an embryo developing in utero. You haven't even been born yet, and your spine is being developed from the germ layers, the mesoderm. And basically, you know, there's a little bit of variation between human beings, right? So this is one of those variation things. And in his case, he just has a small disc at L5-S1, or he's got an embedded pseudodisc at S1-S2. It doesn't really matter. It has no bearing on his life, except we need to identify the proper disc to fix. So we need a reference point in the spine. And many surgeons don't understand this, and they make mistakes and they operate on the wrong level. So ultimately, the patient wants his pain gone. We need to operate on the proper level. To do that, we have to correlate the MRI with the X-ray, and that's what we're doing. Let me know when our blood pressure's a little lower, and we'll get started. We're going to aim from the back. We're going to be approaching the problematic disc at L4-5 on the right side with a transforaminal approach, meaning we're going to bypass the traditional surgeries that are done where a midline incision is made in the middle, and then the surgeon goes down and has to peel all the muscles off the spine. That damages the muscles. It causes horrible scar tissue and bleeding from the surgery. We don't want that. So we're avoiding all that by going around the muscles and around the actual spine. So typically with open surgery, you make a big incision, you have to peel the muscles off the spine, and then you're stuck with these bones in front of you that block your way to the disc. So you have to make holes in the bones, make holes in the joints, and then you have to move the nerve over, and then you have the disc to deal with. And with endoscopic surgery, we go around the bones, we go around the muscles, and we leave them all alone, and we don't do any damage to them. Plus, we have a smaller incision. It's only 7 millimeters. So, tiny skin incision versus a big skin incision, no muscle damage, no scar tissue, no bone is removed, no joints are removed, no ligaments are removed. And we actually are going to be releasing next week our first animation showing just how damaging traditional spine surgery can be, surgeries like the microdiscectomy. All right. Sounds like all right, sounds like the blood pressure is heading in the right direction. Let's just see where we are. I should have given him a little bit of numbing medicine while I was waiting. You're doing fine, I promise you, okay? Yeah, that's just a little more numbing medicine. So, everybody responds differently to the little bit of pain that's associated with the procedure. Some people are basically ambivalent, whereas others are very sensitive. He's fine. Let me see if I can give you a little more numbing medicine. Give me a second. Let me know when it's uncomfortable. Yeah, I see that. So because our patient needs to be awake for the beginning of the surgery for me to do everything I need to do, most notably the discogram and navigating past the nerve root at the foramen. Those are the two important things I have to do. And because of that, I need the patient's assistance to do it. You're doing fine. I promise. Shot? All right. Shot? Good. All right, just give me a minute. I'm working on what I've got to do. You're doing fantastic yourself. Just lay still. So I need to aim for any way we can get that end plate of 4 and 5 a little bit better. I think it's close, but we may be just half a degree, possibly. Let me have some more skin numbing. Yeah, I know. I'm giving you a little more numbing medicine in the skin. You're fine. I was hoping if I went through the old site. You're fine. You're fine. Everything's good. Just lay still for me. Shot? All right, that's better on the X-ray. You're doing great, honestly. Shot. Let's get an AP. So we're approaching the disc at this point. We're very close. I like to use two views, AP and lateral. All right, so we need to be a little bit more medial than we are now. Let's go back to a lateral view. That's why we check the AP view. I want to be right about now on the lateral view. I want to be right next to the facet joint. And we're not quite there. Shot? Just lay still, you're fine. You're doing really good. Shot? Huh? Yeah, I understand. I wish there was an easier way to do this, but I need you awake for this part to help me. It's all about safety and verification of this level. Shot? You're doing good, just lay still. Shot? 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 You all right? We're almost there. Shot? Shot? Brilliant. Just about there. Let's go with an AP. Are you comfortable? We're just about done, okay? I'm literally a minute away. I just want to verify our position. But you've done fantastic. We're going to be able to put you to sleep in a few minutes. Yeah, we're right where we need to be. That's perfect. Any questions for me before we proceed and put you to sleep in a few minutes?
Yes, someone is asking, is the patient awake?
Patient is awake.
Mm-hmm.
Completely awake. So for lumbar discs that we repair, thoracic discs, we need the patients awake to help guide me to where I need to go. There's a very small window, usually about 1 millimeter or 2, that I can go through that's safe to get to the disc, because there's structures around that I need to know whether or not I'm too close to them. One of them is the nerve root, and that's why I need the patient awake. For cervical, like the next case we're going to do, the patient's completely asleep because we don't need the patient's help to navigate. All right, I can actually feel your herniation right now. You feel that? Huh? Yep. I think we found the right spot. Are we okay, guys? So let's turn the lights, Luis, whatever we got to do so the audience can see. All right, I'm very happy with where I'm at. We're in the right disc according to the MRI and the X-ray. This is the L4-5. Now, our patient has injured this disc through some type of trauma, and that's always the first step in every herniation and every disc bulge, every single one throughout the history of time. Okay, the way you get a herniated disc, just so you understand what a herniated disc is, there's jelly in the middle of these discs. It's not like a jelly donut, but it's much thicker. Anyway, it's like a hydraulic jelly. It sits in the middle of the disc, right? And it's walled off, so it can't escape. Even when you bend and twist, it gets under pressure. We doing all right, guys?
Yes, sir. Just for some reason the tower got off.
The tower lost power?
Yes. Checking right now. So,
All right, so what was the issue? So L4-5 is the disc, and the disc is, once again, the jelly is surrounded by a thick wall, literally like a wall of a castle that keeps the jelly in. And it's a little rubbery, but the first thing that has to happen is a tear forms from some type of a traumatic injury, whether it's a car accident, getting rear-ended, or a sports injury, gymnastics, football, golf, something where you twist your spine or tear those fibers, okay? And when the annulus is torn through and through from the inside to the out, that's about a centimeter tear. Now the jelly can actually get out, and it goes right into that tear and pushes through the tear and even can go outside the disc. We call that a herniation. Now, if the herniation is small, it's a bulge. If the herniation is huge, it's a herniation. But truly, bulges are herniations. It's all the same thing. All of his back pain comes from inflammation right in this tear, right here, this zone. And we're going to go in there and clean that tear up so it will heal properly and there won't be any more pain. All right. You comfy? How bad is that on a scale of 1 to 10? 10? Is that your typical back pain? Huh? Is that the location of your typical back pain, that area? But not that severity? Yeah, I understand. All right. Well, that's the bad disc that we're fixing today. So it was a 10 over 10. It is his typical area, just not that severe. You probably, make sure that you don't do anything to bring on that much pain, I'm sure. Okay, good news is we got to put you to sleep now. So when you, I'm sorry? Thank you. We'll take very good care of you. You're going to be fine. When you wake up, that pain will be gone and the disc will be repaired. All right, Jordan, let's get the lights down a little bit and show our audience where the tear is so we can all see it in the back of that disc. Yeah, that's it right there. You can see the guide wire going right through the tear, the needle and guide wire going right through the tear. And that's the intention. We don't want to injure the disc. We want to use the injured area that's already there and go through that area to repair the disc. Shot? So we're not going to cause any new injuries, unlike other types of surgery like microdiscectomy and laminectomy, where you're actually damaging the spine and the muscles and everything just to get to the disc. We're not damaging anything. The only damage we're doing to his body is this right here. It's a 7mm incision in the skin. We make a little cut right where we numbed up, and it's literally a 1/4 inch incision. And through that little incision, the whole surgery will be done. Okay? That's the beauty of this transforaminal technique. Now, I'm not the first person to do transforaminal surgery. How is he doing? Transforaminal lumbar surgery was developed by Parvis Kambin. Dr. Parvis Kambin was an orthopedic surgeon, an endoscopy surgeon. He's moving a little bit more. Let's have some numbing medicine on a long needle, I guess. I'm going to give him a little local, see if that helps. Will that fit in here? Yeah, very good. All right. So there's actually a second port on this needle. I just gave him a little more numbing medicine. He's very sensitive to pain. Very, very sensitive. All right. Lay still. We need you to lay still. So the balance in our patients is always between being comfortable and sleepy enough not to care, but then not doing too much that or too little that they are moving around. So it's really challenging to get it just right, but that's why you need a good anesthesiologist, which we have. All right, I just waited a minute. Do you think I can proceed? Can we work on the 132? Let me just retest. All right, so we're going to do the whole surgery through a little cut. And again, we're not damaging anything inside. All the normal tissues we're leaving. So how is that possible? If you look at the tube that's going in, this dilator, it actually has a tapered end. Is it up yet or no? Oh, it's reading it. It has a tapered end. You can see it on the x-ray. It actually spreads tissues rather than cuts them. So we're not cutting anything. We're just spreading apart. And when we're done, those tissues will come back together just like normal, without any damage, permanent damage to his body. The only permanent thing is going to be the little scar right here. Lay still. You're doing fine. Just lay still. Shot? Let me know when I can proceed. Yeah, blood pressure looks good. Let me know when he's ready for me to proceed. I'm going to wait a minute. All right. So we're just going to wait a minute for the anesthesiologist to get him where she feels he's, optimized. The goal again is to make the patient comfortable but not over-sedate. Lay still. Take your time. So I'm going to pass next with the dilator through that tear in the back of the disc. Let's get a shot. Yeah, the guide wire is still there. It was weird because sometimes when the patient moves while you're taking the x-ray, it almost looks like the guide wire disappears, but lay still. All right, Diego, any questions? Why don't you run the video animation showing why the herniated disc or bulging disc actually cause back pain for people?
Okay.
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right. We're making progress. We're putting our tube down so we can do the surgery. Why don't you show them what we're going to be doing once we get this tube in? Let's run the next animation. Shot.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Here we've got, just so our audience will see, we're on the right side of the patient. You can see the middle of his back here, and the tube is in, and the whole surgery is going to be done through this tiny little 7mm incision. All right. So we're bringing our scope down into the disc. Now we've also stained this disc with indigo carmine. That's why there's a blue stain. It stains the degenerated nucleus pulposus.
Jordan, do me a favor. Turn on that light for them, and turn on this one over here.
All right, we're going to bring the laser in. Get the laser on. Where's my pedal? There needs to be a pedal here. All right. Any questions from our audience? He's going to start feeling this. I cannot move this for some reason.
Just give me a heads up when you're close to where it's very sensitive, and I will give a little more for that part.
Are you ready for a question, doctor?
Yeah, we're ready
Okay.
for a question.
We have a question from Reddit. We have someone saying that they watch a lot of TV and movies, and they've heard about the term surgeon hands. Do you believe in that?
They heard about what?
Surgeon's hands. That people are born with surgeon's hands.
That you're born with surgeon's hands?
Yes.
I don't know. I don't believe that. I think that you're born with perhaps, maybe you could call it a calling to go into medicine. And then once you get into medicine, and I've been through this, and I had 175 students in my medical school class alone at USC in Los Angeles. But, you know, the medical students get there, and for the most part, they don't know what specialty they're going to go into. We all kind of come into medical school, and I would say 95% of the students that go to medical school, on day one, they have no clue what they're going to do. They just know they want to go into medicine. Or maybe they thought they knew. And like, I wanted to be an orthopedic surgeon when I went to med school, but that changed once I learned more about the orthopedics and I learned more about neurosurgery. So, you know, whether or not you want to be a surgeon, I mean, I could tell you story after story about medical students who had no idea they wanted to be a surgeon until they went to med school. And then those that thought they wanted to be a surgeon and then ended up not doing surgery. So I don't know that that's true. I think people are born with a desire to help other people and maybe treat illness, or at least maybe you're conditioned to do that when you're younger. But at some point you decide you want to be a doctor, but I don't really think people are born to be a surgeon. I think their personalities may ultimately lead them. So you're born with your personality, and the personality is kind of what guides you into what field of medicine you want to do. Okay? But I could tell you right now, neurosurgeons are known to have the best hands in medicine. because we have to operate on the brain, and the brain is the most delicate of organs. But I can tell you from firsthand experience that there are about half of the neurosurgeons in my program at UF in Gainesville, which is the top program in the country when I was going there. Half of the neurosurgeons, they were all brilliant, first of all. They all had great grades and very smart, but literally half of them could not operate their way out of a paper bag. Their hands were so bad. I don't want to name names, but my God, I know one doctor who trained with me. He was a year ahead of me, and he graduated and became a vascular neurosurgeon. Vascular neurosurgeons have to have the best hands of all. And this guy's hands were shaking all over the place all the time. Not because he was nervous, but just he had a horrible tremors of his hands. And he made it through the program, and he became a vascular neurosurgeon. I had another guy who was brilliant, and his nickname among the neurosurgery residents, not by me, I would never say anything so mean, but they called him Lobster Boy. They called him Lobster Boy because they said his hands were like a lobster's claw. I'm sorry, but you know, that's certainly not a compliment to the gifting of his hands. Now, he happened to be the smartest of all residents. I mean, probably not the smartest, but he got the highest score on the board exam. I think he had the highest score in the country, as a matter of fact. And I still laugh at it, but I did not make up that name, and I never called him that. I was always friends with him, and he always laughed about it, but I'm sure it bothered him that people called him Lobster Boy. And that's just kind of the stuff that happens in neurosurgery residency. For 7 years, you're with a group of, you know, co-residents, guys, gals, and there are some mean people, and they make up these, you know, these whatever you want to call it, nicknames. My nickname was Dick Major, and that was given to me by the nurses. And trust me, it wasn't a compliment. Oh my God, where am I going with this? There were some bad names. Anyway, not me, but some of the other residents. Anyway, every resident gets a nickname. That's the point. And, you know, for this one resident that was called Lobster Boy, it's because his hands were so bad, he couldn't even operate. It was just terrible. So, I know I'm breaking up the image that people have of surgeons, perhaps, but there's lots and lots of surgeons out there with really bad hands. I'm sure you've seen them, right? Rita? Yeah. She knows what I'm talking about. I remember one surgery I was doing as a resident with this other neurosurgery resident who just became an attending at our program. We were clipping an aneurysm on a patient that was unruptured. We call it a grade 0 aneurysm. And it was an ACOM aneurysm, anterior communicating artery aneurysm. And I did the exposure. Basically, I did the craniotomy without the doctor being there. I did it all. As a matter of fact, it's funny because my wife's son was in the physician assistant program at UF. The same time I was a chief resident in neurosurgery. And so she chose to do neurosurgery, and she was actually in the operating room assisting me clipping this aneurysm on a patient that had an unruptured anterior communicating artery aneurysm. And I did a beautiful exposure of the ACOM aneurysm, and it was sitting there perfect, just about ready to be clipped. And then this doctor came in, my attending, and he got his hands in there. He put the scope in, the microscope, and I could see his hands just shaking, you know. And he was always like that his whole residency, because I did my residency with him. Remember, he was a year or two ahead of me, and then he became signed on as a faculty. Really great guy, by the way. Smart, very funny. I love the guy, wonderful guy. But he went in there, his hand shaking, and literally with a what's called a bayonet, micro bayonet. He started to manipulate the aneurysm just to see about my exposure and how good it was. And when you're doing an aneurysm surgery, you want to put the clip, which is like a little safety pin, you want to clip the neck so that the dome of the aneurysm doesn't get any blood supply, and it scars off and then, clots off and then scars and then it's gone. So that the risk for bleeding and dying goes down to 0. That's your goal. So I had exposed this aneurysm with Sun, my wife, assisting, and it was like literally ready to be clipped. And I asked the attending, can I clip it? And he said, no, let me come in and look at it and make sure everything looks good. And so I waited, and he scrubbed in, and then he came under the microscope, and I moved over to the assistant scope, and I could see the bayonets just kind of with this very gentle tremor. And then the bayonet tip went right through the dome of the aneurysm and popped it. And the whole field filled with blood. Just like a Red Sea suddenly just poured into your... And the thing about aneurysm surgery and why it requires really good surgeons is because it's very delicate. And once the aneurysm dome pops during surgery, it becomes a life or death situation, and the patient can die in a matter of seconds. So you have to stop the hemorrhaging. The patient could bleed to death literally within minutes. All the blood in your body gone through the aneurysm, out. So you have to have what's called proximal control, where you have to isolate an artery that feeds the arteries that feed the aneurysm, one way or the other, which we had, of course. But I just remember being so impressed with like how fast the field filled with blood and how impossible it was to continue to operate with all that blood. You couldn't see what you were doing. So you literally would just sit there and let the patient bleed to death normally, but thank God we had we were at a very good institution, and despite the fact that the attending's hands were shaky, he had an incredible mental faculty, and he had prepared everything properly so that of course the patient didn't die. We saved the patient's life, but we eventually got the aneurysm clipped and then took them down to angiography, and everything was fine. But my point is, with that story, and it's a long story, but not all surgeons have good hands. There's no such thing. I think you're talking about Ben Carson's book, Gifted Hands. He's a pediatric neurosurgeon, was working at Johns Hopkins before he retired. I actually interviewed at Johns Hopkins to go there and work and train there for residency, and I turned them down. They wanted me to go there. I was actually the #1 draft pick in the year that I applied for neurosurgery residencies. I was the #1 selection across the country. And I had chairmen of all the big programs, Hopkins, Harvard, Michigan, Barrow. They were all wanting me there to work as a resident and do my years of training. I selected the University of Florida because of Dr. Roten, and his program was top program. But long story short, not all surgeons have good hands, okay? And I can tell you about 50% of the ones I know of have really no better hands than an average person. So it's just their brains that are really good. They're able to memorize a lot of information and put things together to do a good job in the operating room. Why was I called Dick Major? Because I was not a very fun and friendly kind of guy. In residency, I was very serious and focused. And, I took my responsibility very serious. And I had expectations that the nurses would do their job properly. And when they don't, I actually speak my mind, and that gets me in trouble. So that was why I was known as Dick Major. Because I was like a military kind of guy that was a dick to people that didn't do their job right. And they didn't like that. But I will tell you, I turned it all around. Somebody said to me, you should bring a box of donuts to the nurses. So I did. I brought a box of donuts. And after that, suddenly they warmed up to me. So I just had to bribe them properly. You missed that part, Rita. I turned my relationship around with the nurses in the ICU in the neuro ICU when I brought them donuts and pizza. I only had to do it a couple of times, so they were not really that demanding, to be honest with you. No, I was always known as Dick Major, but they didn't call me Dick Major anymore. They actually smiled at me and were nice, civil. Well, in the end, I had a good relationship. By the way, that's the tear right there, in case you were wondering. That's the tear. We've been cleaning the tear from the inside out. We're now close to the surface. I got 5 minutes left. And you can see some of the pink tissue. That's all inflammation. We have to clean all that stuff out. Why do I have such poor circulation, guys? Is the irrigation empty? All right. Well, I won't be Dick Major right now. Thank you. Do you have any more questions?
Yes, we have a question from Facebook.
Yep.
How can you tell what part
We
of the
have no flow. Why don't we have flow? The fuck? If there's air, it would be pushing air bubbles, and I don't see anything. All right, now I'm starting to see some flow. I'm sorry, what was the question?
Someone on Facebook is asking, is the blue stuff the herniation?
The blue stuff is the herniation, yeah. Yeah, that's the nucleus pulposus, the jelly that's herniated out. The blue dye that I use stains the herniation. It doesn't stain the annular tear, it stains the herniation. Now, if there's herniation in the annular tear stuck to it, which there is, that causes the inflammation in the annular tear, then you will see some blue along the annular tear. That's what I'm looking for, actually. All right, just about done here. This is all scarred up. Now, to me, this herniation doesn't look that scarred. It looks like maybe it's more recent. You know what I mean? It's not like some of the ones we've seen together where there's massive amounts of scar tissue because the inflammation's been going on for a long time. This looks like a more recent type of injury. Now, there's always more scar tissue as you get closer to the end of the surgery because I'm getting closer to the to where the blood supply of the disc is, which is the outer annulus, the outer half of the annulus. And as I get closer to that outer annular fibers, I get more blood supply, I get more scar tissue. That's the tear right there as well, laterally. And again, I'm debriding the tear with the laser. That's herniation right there, the blue stuff. See how it's stuck in the tear? That's what's causing all the pain and inflammation. Again, we discovered this at Duke Spine Institute. I discovered it years ago. We're the first to discover that the annular tear is the source of pain from the disc, and that the reason the annular tear is painful is inflammation from this nucleus stuff right here, the blue stuff that's stuck in the annular tear and scarred to it and causing just massive inflammation. All right, how many cameras do we have now, Luis? How many of these?
We have about probably like 10.
10?
Yes.
So we have enough.
Yeah, I ordered actually 3 camera and 3 lights. More.
Good, and it's the same brand, same time?
Yeah.
And you've tested them?
Yes, sir.
All right, we're going to be done in 2 minutes. Doctor? Now, see at 12 o'clock right there, there's some fat and blood vessels. That's the epidural space. That's where what's called the traversing root is, the root that's going past this disc. This is all scar tissue here, all this white stuff from the herniation in the annular tear and all the inflammation. Just about done. I think this patient's going to be very happy with his results. I need 1 more minute. We're done. We'll go ahead and use an antiseptic, irrigate the wound. I want to look lateral again. Once again, the tear always extends medial to lateral. And so I have to look backwards in the tube, clean it up so it doesn't re-herniate. Now, annular tears can form anywhere on the disc. The disc is circular, so they can form on the back of the disc, the sides of the disc, or the front of the disc. Tears in the front of the disc and the sides of the disc do not cause pain. The reason for that is they don't have the right pain fibers there, the ones that go to the primary somatosensory cortex that you saw in the video. Let's run the video one more time so that people can understand the pain pathway and how pain from a herniated disc and an annular tear makes its way up to the brain so that it's localized to the lower back as opposed to just vague visceral type.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review.
You're alive.
All right, so we're done. I just pulled the scope back a little bit to look at the nerve root, and there's a tiny bit of, there's a nerve root, by the way, right there. And we didn't damage it. It's right outside the scope, and I want to just, give me the laser, please. Come on. Are you fucking kidding me? Anyway, nerve root is there. We were working there. That's the herniation, and there's the nerve root. So, yep, looks good. So with this surgery, it should get rid of his back pain and his leg symptoms. That doesn't go off until I take the tube out.
Wait, sir, you hear him? Yeah, no off until everything is gone.
He's starting to wake up, which is good. We're just sucking out all this stuff. Almost done. Take that. Lay still, you're doing good. Take. Yeah, he's not happy that the tube's still there. Take. All right. Lay still, you're fine. We're done. Just lay still. So as people wake up from anesthesia, they're sometimes confused. They're not sure what's going on. They may not even remember they're in a surgery. You can't expect them to because we put their brain asleep.
Yeah, we don't need that.
You're fine. Lay still. I would grab the camera and the light cable. All right, I'm going to show you all the incision that we use to do the surgery. I'm just holding a little bit of pressure for now. Lay still. Unfortunately, some people are a little more combative than others. Can you see this, Diego? Diego.
Yes, we saw it.
Right there. That's a tiny little cut. All right, pressure and stitch it up and then. All right, any questions you have for me, type them up. And I'm going to come over to the conference room and answer them for you. Ray Tech off. Good job, everyone. I'm going to call our blood loss she's not even a mil. It's like 2 drops.